This talk for Counseling 224 tries to answer the question, why do I want to assess my clients? There is a handout to go along with this talk on the course page. Today, the term assessment includes a broad array of evaluative procedures that yield information about a person. Assessment procedures include the clinical interview, informal assessment techniques such as observation, rating scales, classification methods, environmental assessment, records and personnel documents, and performance-based assessment. Personality tests such as objective tests, projective tests, and interest inventories, and ability tests such as achievement tests and aptitude tests. Tests, then, are a subset of assessment techniques that yield scores based on the gathering of collective data. For example, finding the sum of correct items on a multiple choice exam. Assessment procedures can be formal, which means they have been well researched and shown to be scientifically sound, valid, and reliable, or they can be informal, which implies that such rigor has not been demonstrated, although the procedure might still yield some valuable information. Generally, the greater the number of procedures used in assessing an individual, the greater the likelihood that they will yield a clearer snapshot of the client. Thus, using multiple assessment procedures, or a holistic approach to assessment, should be considered when making important decisions about a client's life. In this text, we will examine a broad array of formal and informal assessment procedures, all of which can be used in the decision-making process. Today, we're going to talk about 6 different reasons for conducting assessment. Let's go through them one at a time. Understanding the client and your client feeling understood are core tasks in counseling, something we strive for in every contact we have with them. There are a couple of curative factors in counseling that are related to understanding. The first is the experience of feeling understood. There is solid research evidence to support the idea that when a person feels understood, they are better able to make changes in their life. Here is one model of the process of feeling understood. In this diagram, it is person A who feels understood by person B. The process begins with B having some understanding of A. Hopefully, this understanding is accurate. Otherwise, the whole process goes awry. Next, B acts toward A based on this understanding. This link is necessary because A does not have access to the contents of B's mind and must rely on behavioral markers. A's experience of B's understanding behaviors, including whether it is noticed and how much influence it has, is mediated by an interplay of situational, relational, and individual difference factors. Barbara Grote interviewed 6 clients about their experience of feeling understood. These 11 themes were identified as essential elements of feeling really understood in the counseling relationship. In a related piece of research, Barbara Condon interviewed 10 people about their feelings of being misunderstood, asking them, quote, "Please tell me about your experience of feeling misunderstood," close quote. They identified these 3 central themes from these interviews. Disheartening insignificance is a burdensome uneasiness of knowing, not knowing how one is viewed by others, as well as knowing, not knowing if one's opinion is understood or heard. Discordant affiliations involves the uncomfortable engaging with attending and distancing others. Resignation with resiliency is a giving up or coming to an accept a situation while at the same time pressing onward with resolve. Silvia Morelli and her colleagues induced felt understanding and non-understanding as participants underwent functional magnetic resonance imaging. Feeling understood activated neural regions previously associated with reward and social connection, the ventral striatum and the middle insula, while not feeling understood activated neural regions previously associated with negative affect, the anterior insula. It is clearly beneficial when our clients feel understood and detrimental when they do not. The relationship between the counselor and the client has been identified as a significant curative factor. Early in psychoanalysis, treatment and the therapist were conceived of as a blank screen onto which the client projected their fantasies and wishes, which were then interpreted by the therapist. Client feelings about the therapist were transferred from early childhood relationships of the client. Interpretation was the curative factor. Any feelings that the therapist had about the client were discussed as countertransference, reflections of unresolved psychic conflict in the therapist, and these were then referred back to the therapist's therapy. In Richard Sturba's 1934 article, The Fate of the Ego in Analytic Therapy, he maintained this individual and unidirectional level of analysis while theorizing that there was an ego observing process in the client that alternates with the transferential process, and suggests that interpretations target the transferential processes. In 1956, Elizabeth Zetzel wrote an article that expanded the concept of the ego observing process and used the phrase therapeutic alliance to describe a relationship that included empathy and support as curative elements in addition to interpretation. Ralph Greenson was a psychiatrist in Los Angeles, perhaps most famous for being Marilyn Monroe's therapist. He also made significant contributions to the psychoanalytic literature on therapeutic relationship. For example, his 1965 article, The Working Alliance and the Transference Neurosis. He detailed more specifically the client's ability to align with the tasks of therapy in what he called the working alliance. One part of this working alliance was a personal bond between therapist and client that was free of transferential elements and had some curative effects in therapy. Edward Borden was a counseling psychologist and more affiliated with the humanistic tradition of Carl Rogers, but he worked to integrate these humanistic insights into relationship with the evolving psychoanalytic conceptualization. He adopted Greenson's term, working alliance, and added an emphasis on mutual identification and agreement on the goals of therapy. It is his pan-theoretical conceptualization of the therapeutic relationship that serves as a foundation for the working alliance inventory, which we will be using in this course. As early as 1913, only a couple of years after he left Freud's Psychoanalytic Society, Alfred Adler was defining a therapeutic relationship that was markedly different from that of his former colleagues. In an early paper on therapeutic technique, he wrote, quote, "A basic principle for the therapist is never to allow the patient to force upon him or her a superior role," close quote. He was quite explicit about the task of therapy as giving the client the experience of contact with a fellow human being and thus awakening their social interest. He saw this as analogous to a parental relationship in the development of the client, noting, quote, "If the mother fails in this, the task is likely to fall much later to the physician," close quote. This relationship is characterized by equality, encouragement, and mutual respect. Another early individual psychology therapist, Erwin Wexberg, wrote an excellent book on therapeutic technique titled Individual Psychological Treatment, in which he described an active and engaged style of relating to the client. This book also makes it clear that the individual psychology therapist views educating the client about their lifestyle as a primary change agent, instead of the insight that is characteristic of the psychoanalytic tradition. Rudolf Dreikurs produced the most definitive statement on the relationship. I think his conceptualization of resistance as a discrepancy between the goals of the therapist and those of the client profoundly defines the nature of the therapeutic relationship in individual psychology. Dreikurs also makes it clear that the interpersonal process between therapist and client and the awakening and nurturing of social interest in the client are important components of therapy. Let's take a look at the client factors that have been found to significantly impact the therapeutic relationship. Then we will look at the therapist factors, and finally we will look at some interactive factors that have been identified. There are a number of studies that have studied the impact of diagnosis and/or severity of impairment of the client on the therapeutic relationship, and the results have been quite mixed and difficult to replicate. Over a number of studies, a trend for people with personality disorders to have a more difficult time establishing and maintaining a positive therapeutic relationship is evident. There is a whole body of research on the relationship of object relations and attachment style, generally supporting the notion that persons with fearful, anxious, dismissive, and preoccupied styles have a more difficult time establishing and maintaining a therapeutic relationship. There is evidence that the client's view of the therapeutic relationship evolves over time. There is strong evidence that a poor alliance at the end of session 1 is a predictor of early termination and poor outcome. There are also findings that the alliance in sessions 3 to 5 is a consistent predictor of outcome in therapy, oftentimes better than measurements that are done in the middle or toward the end of the course of therapy. Empathy is one of the core conditions of the therapist that Carl Rogers identified, along with unconditional positive regard and the congruence of the therapist. To build a good interpersonal bond, the therapist needs to be able to not only accept and appreciate the client's world, but also to individualize the expression of understanding and support to suit the client's relationship stance. Creating a relationship in which the client feels understood is an essential competency for a therapist. That being said, it is also important to note that alliance is a broader concept than empathy, and when assessed independently, alliance makes an additional contribution to predicting positive outcome in therapy. Other therapist factors that have empirical support are an optimistic attitude and the ability to generate hope and open and clear communication. It is easy to see how these factors overlap with one another, and researchers have been very creative in figuring out ways to measure these various aspects. A good therapist has the ability to convey understanding and appreciation of the client's phenomenological perspective, as well as a belief that things can change for the client. Research into the impact of experience and training of the therapist has yielded equivocal findings. There is fairly consistent negative correlation between alliance and training, but a positive correlation with measures of therapist skill. Training may be a necessary but not sufficient condition for a therapist, particularly with more difficult and disturbed clients. Overall, clients with difficulty forming close relationships have stronger alliances with more experienced therapists, while less relationally handicapped clients do not respond differentially to levels of experience. Several therapist factors have been found to negatively impact outcome. A controlling or a take-charge attitude does not seem to work well with most clients. Therapists who are perceived as irritable, cold, or distant by the client tend to have poorer outcomes, as does the offering of interpretation or insight prematurely. Timing in therapy is discussed a great deal, but establishing clear guidelines for good timing has been elusive. There has been a great deal of discussion of the importance of therapist-client match, but little empirical support for any proposed strategy and limited evidence for the impact of any identified dimension on outcome. There is evidence that greater complementarity in terms of dominance and control results in more harmonious verbal transactions between client and therapist through the course of therapy. And this increase in harmonious, positive, moment-to-moment interactions was closely related to a good working alliance and to outcome. This same research found that the opposite was true as well. In other words, similarity in dominance and control styles was associated with more negative interaction and a decrease in the working alliance. There are also a number of studies to support the idea that psychotherapy outcome appears to be considerably enhanced when client and therapist are actively involved in a cooperative relationship characterized by agreement on therapeutic goals and the processes to achieve these goals. This echoes Rudolf Dreikurs in his emphasis on the importance of alignment of goals in the therapeutic relationship. For this exercise, you will need the Working Alliance Inventory Self version and the Working Alliance Inventory Scoring Table. You can download both from the course page. Your scores and experiences with this inventory are a part of the 6-instrument reflection assignment that is due in week 7. For this exercise, you will need the Working Alliance Inventory Self version and the Working Alliance Inventory Scoring Table. You can download both of these from the course page. Your scores and your experience with this inventory are a part of the 6-instrument reflection assignment that is due in week 7. The Working Alliance Inventory is a 36-item assessment instrument designed to operationalize Borden's pan-theoretical conceptualization of the working alliance. It is made up of 3 factors: bond, task, and goal. Because different perspectives can have different views of a relationship, there are 3 different forms available: one for an observer of the therapeutic relationship, one for the client, and one for the therapist. One form or the other, sometimes 2 forms, and occasionally all 3 forms, are widely used in the research on therapeutic relationship. Research has found that client and observer ratings of alliance have similar and strong relationship to outcome, whereas the therapist rating of an alliance is less powerful in predicting outcome. This is extremely important to keep in mind as you work with clients. Just because you feel like you understand the client, it does not mean that the client feels understood. Look at the inventory. Let's go over the instructions. On the following pages, there are sentences that describe some of the different ways a helping dyad may interact. Consider your life experience of helping relationships, especially any clinical relationships you have been in, and rate yourself on each of these items. If there is a very strong evidence that a sentence describes the interactions you have participated in, circle the number 7. If there is very strong evidence that a sentence does not describe the interactions you have participated in, circle the number 1. Use the numbers in between to describe the variations between these two extremes. Remember to use the scoring key for the Working Alliance inventory and to reverse those scoring on items with a negative polarity. A high score indicates a positive aspect of the interactions you have engaged in. A low score indicates a negative aspect. A score of 4, no evidence, indicates an average alliance in these interactions. In other words, a score of 1, 2, or 3 would indicate a relative skill deficit in your past relationships, while a score of 5, 6, or 7 would identify a relative strength in your past relationships. Record your scores using the second page of the scoring table. Place your scores in the cell that has the item number in it. If the item number is in the left of the cell, use your score. If the item number is in the right of the cell, reverse the score. Once you have completed all the items, add up your scores for each of the 3 columns. This gives you a total score for each of the domains: task, bond, and goal. There are two approaches to interpreting your scores. First, you can look at the items that correspond to your highest and your lowest scores. A high score indicates a positive aspect of the interactions you have engaged in. A low score indicates a negative aspect. A score of 4, no evidence, indicates an average alliance in these interactions. In other words, a score of 1, 2, or 3 would identify a relative skill deficit in your past relationships, while a score of 5, 6, or 7 would identify a relative strength in your past relationships. It might be useful for you to recall specific interactions that you were thinking of when you completed the items. You can consider how these items reflect your style of living and your personality as best you understand it. Second, consider your domain scores. Is one noticeably higher or lower than the other two? Does this match your sense of yourself as a counselor? Higher scores indicate a strength in that domain, while lower scores suggest an area for improvement. A third reason for assessment is to monitor progress during treatment. There are numerous ways to do this, and I'm going to introduce you to two of them. I used a variety of instruments in my private practice, and I like these for their brevity and their simplicity. My clients have come to expect these at the beginning and the end of each session. There is a copy of these in the handouts folder on the course page. The outcome rating scale is given at the beginning of each counseling session. There are 4 items, and your client puts a mark on each line to let you know how they are feeling in each area. You review the results with your client right after they complete it as a way of beginning a discussion of how their work week has gone. If you want to record a numerical value in your chart, you use a centimeter ruler. The lines are 10 centimeters long, so you can get a score from 0 to 100 by placing the ruler on the line. The session rating scale is like the outcome rating scale. It is completed and discussed at the end of each counseling session. A centimeter ruler is also used to quantify these scores. For several years, I was the staff psychologist at a 5-day residential and day treatment program for children aged 6 to 12. We produced an integrated treatment plan incorporating assessments of the child's educational achievement, cognitive functioning, and behavior, the parenting style of the parents or guardians, and the family cohesion, bond, and interaction style. We did this by having several members of the treatment each conduct assessments in their area of expertise, and then integrating the material in a team meeting that included the parents and the child. This treatment plan was reviewed and updated every 2 months, and each treatment plan review was preceded by an assessment of the treatment goals. There are times in a clinical practice when you need to screen for some things so you can focus on others. For example, for several years my practice has been primarily in the treatment of insomnia. Many of these clients were quite reticent about a mental health referral, and I did not want to start with a diagnostic interview. Instead, at the end of the first session, I sent them home with the Level 1 symptom measure from DSM-5. We will be looking at this questionnaire in more detail later in the course. It helped me to identify possible mental health disorders without extensive interview time. Finally, most research involves measuring and quantifying the variables that are being researched. Assessment instruments are a common way to turn a concept into a number, to produce data that can be analyzed with statistics.